Any antibiotic use in the last 90 days is a major risk factor for drug-resistant strep pneumo. Now, why is that? Well, think about it. That prior course of antibiotics acted like a filter. It wiped out all the weak, susceptible bacteria hanging out in the patient's respiratory tract, right? And it effectively selected for and left behind only the tougher, more resistant strains. So now, those are the bugs that are causing this new infection. Because of that huge risk of resistance, monotherapy with just one drug is off the table. It's not enough. We have to escalate our attack. We have to use combination therapy. The standard approach is a beta-lactam, like a cephalosporin, to hammer the cell wall of that resistant strep pneumo, plus a macrolide to also cover our bases for the atypical pathogens, like that Mycoplasma we just talked about. What exactly is non-resolving pneumonia? Well, it simply means the abnormalities on the chest X-ray are sticking around way longer than we'd expect. And here's an important nuance. The patient might actually feel a lot better. Their fever's gone, their cough is improving, but the image, the film, isn't clearing up. 1 month. Most cases of community-acquired pneumonia should show pretty significant improvement on the X-ray by then. If things aren't looking better by that 1-month mark, you have to stop and investigate for another cause. This is your 4-point diagnostic checklist. Number 1, host factors. Is there something about your patient that's preventing them from clearing the infection? Think undiagnosed diabetes, HIV, or even just being over 50. 2, antibiotics. Did you pick the right drug? Is there a resistance pattern you didn't account for? 3, complications. Is there something else going on, like an endobronchial obstruction from a tumor, a lung abscess, or an empyema? All of these can look like a pneumonia that won't go away. Could this be a bug that your standard antibiotics won't even touch, like Mycobacterium tuberculosis or a fungus? Your job isn't done at discharge. Thinking about prevention, making sure they're up to date on their pneumococcal and flu shots, counseling them on smoking cessation.
So here's the story. We have a 14-year-old boy. He has a lifelong history of problems, chronic sinusitis, getting one pneumonia after another. He's constantly coughing up a ton of thick, yellowish sputum. Now right there, your brain should be thinking about conditions that mess with mucus clearance, right? Something like cystic fibrosis might pop into your head. But then you do your physical exam, and you find something absolutely bizarre. His heart sounds are loudest on the right side of his chest. So now you have to step back and ask, what single diagnosis could possibly connect chronic sinus and lung infections with the heart being on the wrong side of the body? When mucus just sits there, it becomes a perfect swamp for bacteria to grow. That leads to this vicious cycle of infection and inflammation. Over years, this cycle literally destroys the airways, causing them to get permanently stretched out and dilated, a condition we call bronchiectasis, which explains all that sputum. But the real knockout punch, the clue that ties this entire puzzle together, is the dextrocardia. A huge structural abnormality like that tells you the problem started way back during embryonic development.
The root cause here is a genetic disorder called primary ciliary dyskinesia, or PCD. So all throughout our airways, we have these microscopic, hair-like structures called cilia. Their job is to beat in a coordinated wave to sweep mucus up and out of the lungs. It's called the mucociliary escalator. While in PCD, there's a genetic defect, and those cilia just don't work right. They're either paralyzed or they beat in a totally disorganized way, so the escalator is broken. Mucus gets stuck, bacteria party, and the patient gets sick over and over again. And here's the kicker. Those same cilia are also crucial during fetal development for telling the organs which side of the body to go on. When they don't work, everything can get flipped, leading to a mirror image arrangement called situs inversus.
And that brings us to the diagnosis you need to know. While the underlying genetic disease is primary ciliary dyskinesia, this classic triad of findings, situs inversus, chronic sinusitis, and bronchiectasis, has its own special name, Kartagener syndrome. It's important to know that not everyone with PCD has the situs inversus, but when you see that full triad, that's Kartagener's.